Okay, good morning, everyone. My name is Ellen Barra, and I'm with our Provider Outreach and Education team. On the call with me today is Rachel Wood, who is one of our nurse analysts within our Provider Outreach and Education team. What we're going to be talking about here today are evaluation and management services, specifically critical care documentation, and we're going to be going through some actual examples of critical care and identify whether Medicare would agree that this would be critical care or not. The next slide that we have up for you is our disclaimer, and we provide this during all of our educations. The education that we're providing to you today is as accurate as we can make it as of today. However, if you've been with Medicare for any length of time, you know that Medicare rules do change, and evaluation and management services have changed quite drastically over the past couple of years. The relevant laws, regulations, and rulings on the CMS website are the final determinants of coverage along with your documentation. We will provide responses to questions based on the way that you're asking the question, but of course, Medicare rules and documentation determine the final coverage. And then that last bullet point, CMS does prohibit recording of this presentation for profit-making purposes. So if you are recording or if you're doing screenshots, we would ask that you not do that. We are recording this presentation. We will have this available for you as an encore presentation, and that will be available through our website to start with, and then also on our YouTube channel. The other thing I want to let you know for purposes of this slide is that we have reviewed this documentation based on the Medicare rules and regulations, and then our clinical judgment concerning the information within the documentation. As you're aware, evaluation and management services are a lot more subjective than some of the other services. Documentation for a chest x-ray, for an example, is pretty straightforward. Either it's there or it's not. Evaluation and management services, however, as I stated, can be a little bit more objective. So if you are part of a medical review audit, either through WPS, through the CERT contractor, which is the Comprehensive Error Rate Testing contractor, the Supplemental Medical Review contractor, Office of Inspector General, etc. If you disagree with the responses and how we say the claim should have been coded, appeal it. In your appeal, though, you want to be very specific in why you believe the service is coded appropriately. Unfortunately, what we receive a lot of times in these requests for appeals is simply a statement stating, look at the documentation. Well, if this has been part of a review, an actual medical review, we've already looked at the documentation and we've already made our decision. So unless there is additional information or unless you can point us at what you believe really makes this service payable as you have coded it, we're probably not going to reverse our decision. So just in your appeal, if you disagree, you have that appeal right. Just be very specific. So let's start talking then about examples of documentation. So this is example number 1. You can see here we have a chief complaint of shortness of breath and cough. We have a 53-year-old male who complains of dyspnea. He's been ill for the past week. His mom has also been ill just a little bit longer, and she's actually there with him in the same room. So the physician in this case is actually looking at both of them. They both have a productive cough and congestion. The patient was given medication by his pulmonologist, but it continues to worsen. You can see there his oxygen saturation rate, both at home and for the EMS staff, were in the 80s. And he's currently on oxygen 2 liters by nasal cannula. The situation here is that the patient and his mother were both brought into the ER for a cough and shortness of breath. So the patient has been ill for a little while during the last week, but he continues to worsen. So now we have the exam information for him. We've got a high respiration rate at the beginning of the service. However, the pulmonary section of this exam does state that the pulmonary effort is normal and the patient is in no respiratory distress. We do have wheezing that's present. So you can see there the respiration rate started at a 26 and then came down to that 15%. The oxygen rate is only shown for that last vital sign, and that is at 95%. The patient is not toxic appearing. He is diaphoretic, which means that he's sweating. As we look further in this information, we have that the provider did order numerous lab tests for this patient. They also ordered numerous radiology studies. We did not include all of those lab tests within the documentation you have. We can see the differential diagnosis here: pneumonia, possibly a pulmonary embolism, COVID-19, asthma with acute exacerbation. Because of the patient's developmental disability, they were kind of having trouble taking care of this patient. You can see at one point there it says there was a considerable delay in obtaining the CT due to the patient kept leaving his room to go be with his mom, taking out his own IV, stuff along those lines. So I think this patient was kind of challenging. The practitioner also documented his or her review of the CT scan. And then we have information here showing the time. Now, the doctor is indicating that this is critical care time, spent caring for this patient, doing the reviews, all of that kind of stuff. But again, let's think about some of the information we've seen. On the previous slide, that pulmonary exam showed that or the information there showed that the patient's pulmonary information was normal. Pulmonary effort normal, no respiratory distress. There was some wheezing that was present. It also indicates here that this provider service is separate from the attending physician. So this provider could have been called in by that ER physician to deal with this patient's problems. So now let's look on the next piece of information. And here we have information that shows acute respiratory failure with hypoxia. Now you'll notice on here that this indicates the CMS HCC, which is the hierarchical condition codes. Medicare fee-for-service does not use these codes. These are generally for your Medicare Advantage plans. And in addition to that, the information we have on the other pieces of our documentation don't really support acute respiratory failure. The doctor does say that the patient's oxygen saturation rate when he came into the ER was in the 80s, but then we have vital signs that show it went up to 95%. We have information that shows the patient could have been COVID or could have had COVID, could have had pneumonia. Excuse me. But then we also have pulmonary information indicating that there's no acute distress. It looks like the final diagnosis that they have here is the multifocal pneumonia. And so it does indicate that the provider personally examined the patient, confirmed the history as documented by the mid-level provider, reviewed orders and results, and discussed the plan with the mid-level provider and the patient. It appears, and they make the statement, I performed a substantive portion of the medical decision making as outlined below. Says that he performed an exam. Patient appears ill, but remember on another piece of this information, we didn't have that. We have hypoxic and frequent coughing. So this particular exam or piece of documentation is really kind of interesting because it denied based on another provider submitting the same procedure code for the same date. And what we have up here on the slide for you is the B20, that's the reason and remark code, which states procedure was partially or fully furnished by another provider. The appeal request, you can see there, I copied directly what came out of our appeal request, which is please review the attached reports that support payment for the procedures. Well, that really doesn't tell us anything, does it? And it doesn't go along with the reason why this particular service was denied. So again, the claim denied because someone else also billed that 99291 procedure code. Now, when Medicare is editing for this code, we edit based against the same group with the same specialty. So in this particular case, another provider in the same group with the same specialty had also submitted a 99291 procedure code. So Medicare's not going to pay for two. This particular service could have been a 99292, depending on the time from the other provider, or this may not have should have been submitted at all. A 99291 is for the first 30 to 74 minutes of critical care. This provider did indicate that they provided 35 minutes, but they did not supply us with any documentation from the other provider. Since they're not providing us with any information and what they put on the appeal request itself, the documentation did not help address the reason for this denial. In addition to that, the documentation states that they discussed this with the mid-level, and they are indicating by doing the exam that they have provided the substantive portion of the medical decision making. So this would indicate to Medicare that they have provided a split or shared service. The claim should have indicated a modifier FS to indicate that it is split or shared. They did indicate in that one picture on the right-hand side of your screen where it shows 23Y, the 99291 with the 25 modifier. The modifier 25 would generally indicate that the provider also performed a procedure, such as a surgery. There's no documentation that would support that a procedure has been done. A modifier 25 could also have been used if the physician provided the ER service and then the patient's condition changed and then they provided critical care services. Again, we don't have documentation to support this. I believe in looking at this documentation, we were a little lenient in evaluating for the use of the 99291 procedure code. So, but we do believe that the claim supports a critical care service. we're still not going to pay for this service because someone else has already billed for this. So pretty much in essence, the person who submitted this appeal really kind of wasted their time because they're not addressing the reason for denial. In addition to that, they are delaying any appropriate payment back to that physician because they're not addressing the reason for the actual denial. If in evaluating a denial such as this, what you need to be looking for is who else billed for this 99291 procedure code, and then is my procedure code correct? Should I have billed a 99292 procedure code instead? So for this information, Medicare would not have approved this. So example number 2, you can see there that we have multiple problems that are listed. Some of these also are identified by the use of that HCC acronym, which again is that hierarchical condition codes. Medicare fee-for-service does not use these. So when we're looking at documentation, what we're going to be looking at for the diagnosis is what did that physician or practitioner, what did they actually treat for this particular patient? So Medicare fee-for-service would only consider these when the documentation shows how these are related to the problems that are being addressed. The patient was admitted to this hospital stay and to the IC unit for this one based on having had a coronary artery bypass graft or the CABG procedure. So now we have information concerning the plan, and there's a lot of different information that is listed here. We have the neuro, we have pain is controlled. Well, where's that pain coming from? We have history of Parkinson's, but more than likely that pain is coming from the CABG. So what we're looking at here is, should these services be part of the post-operative of the surgery and of that global surgery package as opposed to a separately payable service? We have information on the cardiovascular system. We have information on respiratory. They're going to remove the tubes on 9.2, which is our data service. Again, and these tubes are part of that post-operative care. The documentation shows low lung volumes. So what we would be looking for there is that part of that surgery? Based on the documentation, it's really part of the surgery. We have information based on renal. We have a Foley catheter that is going to be removed the following day. Again, how is it not related to the surgery? We have that we're continuing to hold warfarin. Okay, that makes sense because the patient had surgery. We do have information that the patient's A1C is at a 6.1 and then the documentation shows continue with MDCF, microbiome directed complementary food. The activity level is ambulating in the halls with nursing and cardiac rehab 3 times a day. So one of the things we notice in just this plan of care right here is, what are we doing for this patient that's not related to that surgery? Why isn't the surgeon kind of monitoring and taking care of some of these different things? If we continue on, then we have information on data. And you can see the different times that the patient's blood sugar was taken for this date. And we do see that it's coming down. We started at 172, we go down to the 144. The INR results are still higher than what would be appropriate for this patient. And the chest x-ray also shows that things are improving. When we look at the next slide then, the practitioner indicates that they discuss this patient with the critical care attending and with the surgeon. We have a statement in here that says patient is critically ill and at risk for life-threatening deterioration. We didn't find this anywhere in this documentation. From the documentation, this practitioner is treating conditions or treating the conditions listed as active for that patient. So that kind of leads us to the next question. Well, what is the critical care attending treating? And we don't have the documentation for them. But another question would be, what postoperative services is the surgeon taking care of? The patient is status post-op CABG. They were placed in the ICU for postoperative care. This provider is treating, and the documentation supports that they are maybe treating some additional diagnoses, but the surgeon has the responsibility for postoperative treatment. There's no information in here as to the specialties of the providers involved in treatment. If this was critical care not related to the postoperative care, then modifier FT should have been reported. We did not, or the CERT contractor reviewed this, and in our separate review of this, we did not believe that this met the definition of critical care. So we downcoded this, or the CERT contractor downcoded this to a subsequent level of service. We do have a problem level of high. Documentation supports one or more chronic illnesses with severe exacerbation, progression, or side effects of treatment. The patient's A1C is higher than it should be and could have been the result of the CABG. We also have listed that the patient has Parkinson's. We have data. They are reviewing the lab services and the chest x-ray. We also have discussion of the patient's care with other practitioners. And we have determined this is a moderate risk. The instructions are to ambulate the hall with nursing staff. There are also suggestions concerning that cardiac rehab now become involved with this patient. So example number 2 is an example of something that we do see quite often when we have multiple practitioners who are involved with patients who are in critical care. We did a webinar yesterday on the rules behind critical care, and that should be, if you didn't attend that, that should be available as an encore presentation sometime within the next 30 days. But one of the things that we want to look at when we're billing for these services and when we're evaluating these services, excuse me a second. Is what really is the medical necessity for these providers to be involved. In this particular instance, and we know we have a critical care attending because this doctor, whoever this was, actually stated that they talked to that person, they consulted with that person. We also know that we have a surgeon who was involved in that patient care, and as part of the global surgery package, has already been reimbursed for that global care relating to that surgery. So we want to think about this for a second. This patient has at least 3 different providers who are going to bill for a service on this particular date. Why? What's the medical necessity for all of these providers to be part of this patient's care? In this particular example, example number 2, the CERT contractor did allow it. They did down code it to the 99233, but they did allow the service. You want to make sure when you're submitting documentation to Medicare, when you're getting ready to bill for a service, that your service is medically necessary for that particular patient. Not just that the hospital says all of these type of specialties have to be involved, or the critical care attending could have treated the issues and concerns that were addressed in this documentation, but instead called in someone else. Well, why did they call in someone else? That's documentation that we would want to look at also. So now let's go on to example number 3. And again, we have documentation that really doesn't seem to go together. At the top of the page, our general impression indicates that the patient, and I quote, not in acute distress. We have, under the neurology or neurologic, we have minimal responses or minimally responsive. You'll notice that the information does not address the hypoxic respiratory failure. This patient is also status post-CABG. We do have possible pneumonia. We have low blood pressure, and we have acute kidney injury that's listed, but not really any information to support that. We also have delirium that's listed there. I don't think we have information to support that also, other than the fact that the patient is post-CABG. So now let's look at our plan. This does show significant improved respiratory and hemodynamic status. They're off the vasopressors. Kidney output is still low. Patient is still being sedated. It also states that they can wean the patient off the intubation as tolerated, indicates the patient has a pulmonary infection, and patient has a plan for the continuous renal replacement therapy. The patient isn't ready for extubation at this time, and it does show the critical care time of 33 minutes. When we evaluated this one, we did determine that critical care is appropriate for this, and based on the time that was submitted, that 99291 procedure code is appropriate. Again, keep in mind the things that we kind of identified in that example that really didn't seem to go together. You know, we have patient is not in acute distress, but then we have other information that indicates that there are some things that are going on there. Now let's look at example number 4. This was a very interesting piece of documentation. So the patient came in, and this starts out where the patient is presenting to the emergency department. The patient has a nosebleed, and they're identifying there that the patient is not dizzy. They don't have any trauma that has been identified. She is getting blood down her throat, but is also coughing up. It states in here that it started about an hour prior to arrival. She does not have a history of nosebleeds before this. She's not on any blood thinners except for daily aspirin. She hasn't had any falls or trauma, anything like this. So it indicates the review of systems. I performed a complete review of systems, and positive and negatives are documented in the HPI. All other systems are negative. So now let's continue on. We have an ENT exam. So it's showing here external ear and nose and throat exam shows no gross deformity. Mucous membranes are moist. Left nostril looks to have a larger clot than the right, but they do have clots in both. There's no overt bleeding in the back of the throat. Now let's look at the next piece of information here. We do have blood pressure indicated, and you can see there that her blood pressure started out pretty high at 224, and then it began to come down, 175, and then 106/55 was the last one. They did have a discussion with the consultant, and then they notice, or then they tell us the time. 45 minutes of critical care time, taking care of this patient, including recurrent visits to the bedside regarding excessive bleeding. So let's look on at the next part of this. This shows the medications that the patient is on and were given within the ED department, and then also lab results from that ED visit. The documentation here starts out showing that the patient has minimal bleeding, but the bleeding did get worse. They decided to pack the nostril with a rhino rocket, and they did this actually in both nostrils. The practitioner comes back to the bedside and they're coughing up more blood, and they have identified this at 30 minutes after the original bedside service. They did set up suction for this patient. The provider contacted the ear, nose, and throat people, and she's now also throwing up with this. So as you can see in this situation, we start out with an ER visit, and we have this ER visit for the nosebleed. Well, the physician is dealing with the nosebleed, and then the patient's nosebleed then gets worse. They're doing a procedure, and even after that, the patient's condition again gets worse where they're bleeding more. They call in a consultant to go, to come and see this patient also. And then they identify the time, and they identify this time as 45 minutes, I believe. Let me go back to the slide. So you can see on this one, it says, please note 45 minutes of critical care time were done to take care of this patient. So then as we go on, what we decided for this particular piece of documentation is that it did not support the critical care service. We believe that this was an ER visit, emergency room visit. So we coded this as the 99284. The problem is moderate in the fact that, the patient is dealing this or bleeding. This is a new problem because the patient does not have a history of this. This is an undiagnosed new problem with uncertain prognosis. Patient does not normally have nosebleeds. The practitioner does not know at this time what is causing that nosebleed and the continued bleeding. The data is moderate. The patient had conversations with other practitioners and did review multiple lab tests. The risk to the patient from this treatment plan is low at this point because the practitioner is giving her a referral to the ENT, and there's no additional information within the documentation that would indicate the provider thought the risk to this patient was anything other than low. The documentation did show that the patient had a change in condition. However, we don't have time documented for both. The patient was not critical at the start of the service. We believe the time identified of 45 minutes includes that time before the patient really started bleeding. Now, with more information, we may have been able to code both. The Medicare rule states that if you provide an ER service and then the patient's condition changes to meet the critical care requirements, you can bill both as long as your documentation supports both separately. So the doctor did give us 45 minutes, but that 45 minutes does not indicate that that is separate from the emergency room visit he provided to that patient. The other thing the documentation doesn't really support is when the provider started thinking that this patient was critically ill or injured. Because based on the documentation, we have 3 different bedside services by this provider. We have the first one where the patient's bleeding, but it's not excessive at this point, but they can't get it to stop. Then we have a second bedside encounter where the bleeding is worse and the provider inserts the rhino rockets into both nostrils rather. And then we have a third bedside visit where now the patient's really bleeding a lot more. The patient's condition identifies that they're taking a lot of blood down their throat. They're throwing up, they're dislodging the rockets, etc. But based on the way the documentation is presented, we would have downcoded this to a 99284. So that's the information that we have to provide for you based on the documentation that we have evaluated. What we're going to do next then is we're going to ask Rachel to identify any questions we've received within the chat.
So at this time, we do not have any questions.
Okay. We do have, when we're looking at this documentation, we're taking a look at what the information coming back, or the rules and regulations coming back from CMS, and then just the documentation itself.
So our first question is, for the last example, why would you give low for the risk if they gave medication in the ED? Why wouldn't that be moderate for risk?
When we evaluated the documentation, we're looking for the risk to the patient from the medical decisions that have been made. One of the things that people are getting a little confused on is the items that are in that risk category are examples. So for an example, if you ordered medication, prescription medication for the patient, then it could be a moderate risk. It does not mean that it's always a moderate risk. The rest of the documentation has to support that. Based on our evaluation of this documentation, and I'll just tell you, it wasn't only me that was looking at this. We had Rachel who evaluated it, and also a member of our medical review staff. We did not believe that this documentation supported higher than a low risk for this patient. Next question.
All right, and then our last question we have for example, I'm sorry, actually we did just get one more put in. For example 4, can you explain why it would not be 99285? I'm seeing high data with category 1 met by ordering 3 tests, the CBC, INR, and BUN, and there was discussion with other providers. So in this case, they referred to the ENT. Also giving morphine through IV would support the perennial controlled substances.
Okay, what we have, and hopefully I didn't write this procedure code down wrong. I don't have them in front of me. But what we chose was the 99284, but we did choose moderate problem, moderate data, and low risk. So I hope I haven't messed up that code. But the 99284 is what we came up with. We'll take a look at that to make sure I didn't mess up the procedure code. Next question, Rachel.
All right. Do the actual words critical care have to be documented? Can the provider say they spent 45 minutes on the case, and from that documentation, can you tell that the patient's condition is critical and the provider's intensity of work meets the CPT criteria?
Medicare does not require any particular language. So what we mean by that is that if your physician does not state the words critical care, that doesn't mean that we won't approve it as a critical care service. So if you're billing that to us as a 99291 or 99292, as long as your documentation supports the requirements, which is the patient condition, which we talked about in our webinar yesterday, and then high complexity decision making, as long as that's documented, then you can have a 99291. On the opposite side of that, as we've seen in some of these examples, just because a provider is stating critical care or the patient is in the critical care unit does not necessarily mean that the service is actually critical care and should be reimbursed as such. It all goes back to that documentation. As we showed in a couple of these examples today, documentation in some places really didn't match. In one place it showed patient in no acute distress, and then another place that we had another place in the documentation, it said acute something, and then they're billing critical care. Well, when we're evaluating that documentation, which is the most valid piece? Patient in no acute distress or patient is really having a critical issue. So it all comes down to the documentation. What is in there? Does the patient meet the condition requirement? Let me get my presentation from yesterday and read that to you real quick. Wrong one. Okay, so the documentation we're going to be looking for that patient is acute impairment of one or more vital organ systems such that there is a probability of imminent or life-threatening deterioration to the patient condition. That's based on your documentation today, not yesterday. You know, the patient could have been very critical yesterday, but what are they today when I'm doing that service? And that's what we're going to be looking for in the documentation. Next question, Rachel.
All right. Can you provide any examples of shared critical care with APPs?
Well, we do have that one piece of information where the doctor is indicating that they talked to and the APP was also involved. I don't have examples of documentation from both practitioners that would show the APP documentation and then the physician documentation on top of that. That though,
All right.
let me just throw this in, Rachel, I'm sorry. What we would want to see in that documentation is who is doing what and how much time they're spending for a critical care service. We got a question yesterday about whether or not the physician could use an attestation statement, simply indicating I worked with the practitioner, I agree with the practitioner. What we're looking for is what did that provider do? Exactly what service and how is that service the substantive portion of that particular service for that patient? That's what we're looking for in the documentation. Sorry, Rachel, go ahead.
All right. And I believe that is it. We did get one question sent to me privately that I think I'm going to send to you, Ellen, offline.
Okay.
So otherwise, I'm not seeing any questions in the chat.
Okay, well then on behalf of Rachel and myself, we want to thank you for attending this presentation today. We do encourage you to take that survey to let us know of any additional pieces of education or topics that you would like to see us present on. You can also use the email address that we gave you. If you're willing to share redacted documentation with us that you would like us to use for education to everybody, contact us. We can work with you on that. Medicare has not been reviewing E&M services since COVID, so we don't have a lot of documentation examples to use. We can expand our education if we receive examples. So again, on behalf of Rachel and myself, thank you very much for your attendance today, and you can now disconnect. This will end our webinar.